Tracy Lieu is going to be talking to us, Dr. Tracy Lieu. She is the director of the Division of Research over at the Kaiser Division of Research, their very big research enterprise over at Kaiser. She manages 500 people to do lots of research actually throughout Northern California in the Kaiser population. She comes fairly recently from Boston also, where she was working doing this is where she did much of her work on vaccines and also other general pediatric subjects like otitis media. And she's been funded by the NICHD as well as AHRQ for the work that she does. And she is an elected member of the Institute of Medicine. So it is a great pleasure and privilege to have her with us here today.
So, before we get into the heart of the content of the talk, let me tell you a little bit about the setting that I'm in, because often people are curious about what Kaiser Permanente Northern California is or what our Division of Research is about. Kaiser Permanente is a national organization, and in the Northern California region, we have about 3.5 million patients. And the medical group and the health insurance plan have a really distinct focus on quality of care. Within the Division of Research, so our Division of Research is actually embedded within the large healthcare delivery system. We do have about 500 people, and about 50 are faculty-level researchers. But, UCSF has 2,400 faculty, so we're very small compared with you guys. And we look very much like a department in a medical school or a school public health setting. We bring in most of our funding from NIH or other external funders. We have a portfolio of about $75 million annually, and we do have 20% internal funding sponsorship. So we look not so different from you. And when you call us and say, would you like to collaborate, we're often saying, yeah, great, how can we chase funding together? And many of you in this room know what that arrangement is about. So we're very open to collaboration. Our research portfolio spans epidemiology to implementation science. We don't do bench science. And actually, UCSF looks over and thinks that we have some complementary interests to some of the really interesting bench and translational work going on here. All right, so today's talk is really about stories, and these are stories about the coevolution of science and policy. And the first will be about how vaccine safety research has evolved, and how researchers in this field faced data privacy and methodologic challenges. And secondly, how this research field then spawned modern methods for dealing with big data. The third part of the talk is some new work. It's actually fresh work that I haven't even completely processed, but you may have some useful advice for me about what parents today tell us about how to improve the process of vaccinating children. So the first part of this is really in the context that parents these days are increasingly hesitant about vaccines. All of us who practice general pediatrics, which, by the way, I do just 10% of my time, know that vaccine refusal has been increasing. It's more and more of a challenge to us who are in practice. And you can sort of see that in California, from this chart, this was in the San Francisco Chronicle in February, about 3% of people completely refuse vaccines for their children. So that's a very, very small percentage. But the percent that is adopting different kinds of methods of vaccinating and asking physicians to space out their vaccines is actually increasing. Vaccine refusal is linked with epidemics. There's actually pretty good evidence that pockets of vaccine refusal are associated with outbreaks of measles and pertussis and some of the other vaccine-preventable diseases that we've seen reemerging. And if you follow the news at all in the early part of this year, you know that an outbreak started around Disneyland. In 2014, measles was starting to peak. I think 2015 is off to a very fast start as well. And it'll probably be a while before these measles epidemics come to a plateau. Likewise, a year ago, we had a whooping cough epidemic, the second in 4 years, also associated with pockets of underimmunization. Vaccine safety is parents' greatest concern. That's actually very consistent when you look at surveys of parents. And, so what are we doing about these concerns? it turns out that the U.S. has multiple federal groups who are involved in vaccine safety research and policy, almost too many in a sense, because these groups don't always coordinate in the most optimal fashion. But the Vaccine Safety Data Link project, which is led out of CDC, is actually the original premier active safety surveillance program. The FDA has something called the Vaccine Adverse Event Reporting System, which is a passive surveillance system, and then has recently, within the Sentinel Initiative to study drugs and vaccines and post-licensure safety, started something that is called the Post-Licensure Rapid Immunization Safety Monitoring Program. So these two programs, the Vaccine Safety Data Link Project and the PRISM program at FDA, are both active surveillance programs. The National Vaccine Program Office gets involved. The National Vaccine Injury Compensation Program handles claims from parents who believe their children were injured by vaccines. So I actually spent a lot of the last 2 decades in vaccine safety research. And I have to say, it can be a very frustrating area of research. Researchers in this field face multiple challenges. It's just like this perfect storm of methodologic issues. And for one thing, adverse events in vaccines are rare. So you therefore need very large sample sizes to do studies that are adequately powered to reach definitive conclusions. In addition, almost all children are still vaccinated. Complete refusal is only 3%, and those families probably look different from other families. So there's really no simple comparison group. When new vaccines are introduced, the public wants information pretty rapidly. They're not sort of interested in saying, oh, we did a study on data that was 2 years old, and now we can tell you that this vaccine causes Guillain-Barré syndrome. Influenza vaccine comes out, and the public wants to know right away whether your new vaccine is causing that issue. So the Vaccine Safety Data Link project was actually one of the first projects in the country to create a modern research data network. And what is a research data network? This was started in 1990 by a young CDC project officer named Bob Chan. I actually saw Bob just last Friday. He was in town for the American Epidemiologic Society meeting. But he was a young guy back then, and he just sort of said, how are we going to solve this problem? And he went around to some very senior epidemiologists around the country, and they said, what you need is big data sets of integrated healthcare systems that have excellent longitudinal follow-up on their patients and that capture all of the data on those patients. And he went around to different health maintenance organizations, primarily the Kaiser Permanentes, but also Group Health Cooperative in Seattle, Health Partners, just different healthcare systems. And he got people to sort of believe in the idea that we could align our data and link them all up and do these large studies of very large populations. So today the project includes 9 healthcare systems. They're mostly HMOs. We have data on about 9 million persons in the cohort. It's about 3% of the US population. And the birth cohort is about 100,000. So these are the sites that are currently involved. And it happened that when I took my first assistant professor level position at Kaiser Permanente, I was involved here in Northern California. Then I moved to Harvard, where we started a site at the Harvard Pilgrim Healthcare Institute. And now I'm back and actually only a little bit involved in our site because other people lead it. But have been in and out of this project for a while. So VSD created these very large linked databases of vaccination records and hospital and ED discharge records and outpatient visit diagnosis codes. We had enrollment and demographics. We geocoded so we could get census tract level, neighborhood level information on these children. And we're also linked with birth and death certificate data. So all of these data sets are linked by study IDs. And by the way, if you're in pediatrics and want to study child health outcomes, this is actually potentially a really useful data set. It actually, well, you'll see, but it doesn't, the data set does not live in a single location right now for reasons that we'll talk about. So interestingly enough, the first 10 years of this project, the project did not really create very much useful information. And people are looking over saying, okay, you guys have linked these data sets and you've done a lot of preliminary analyses, but there weren't really opportunities to do important studies. And suddenly, what happened in 1998-99 was that the FDA system, so the Vaccine Adverse Event Reporting System that does the passive surveillance, started to get these signals of intussusception after RotaShield vaccine. So RotaShield is no longer on the market, but it was the first vaccine licensed against rotavirus. And then by 1999, VAERS was receiving these reports of intussusception. So what's intussusception? If you're not a pediatrician, it is a telescoping of a small bowel on itself. And it's really dangerous. The small intestine can die. If the small intestine necroses or dies, the child is at risk of death, actually, but needs an operation and often winds up with this thing called short bowel syndrome, which is just the most terrible condition you can imagine, because it's a lifelong chronic condition where they don't absorb nutrients. And, we as pediatricians see some real train wrecks in this setting. So even though this is very rare, it's something you want to avoid at all costs. So was RotaShield linked with intussusception? I was at Harvard Pilgrim. I got a call from an officer at CDC. They said, "Can you send us some data right away?" I sort of said, "Okay, what for?" And they told us the hypothesis, and we put the data from all of our sites together, did a retrospective cohort study, and found that, in fact, the odds of intussusception after RotaShield were 30. You almost never see this in epidemiologic studies, but clearly there was increased risk. The attributable risk was really tiny, but even with this tiny risk, as people started to talk about this relative to the risk of rotavirus infection, which causes diarrhea and sometimes hospitalization, but is probably not usually life-threatening in the US, the manufacturer, Merck, decided to just remove the product from the US market. And then actually some more research was done, and these days we have RotaTech vaccine and modern vaccines against rotavirus. But this first vaccine actually failed because of safety concerns. So that was the project's first success, but immediately after we started to face big challenges, and they were political challenges, they were policy challenges. And this went on for almost a decade. There was a concerned Congressman, Dan Burton. He was the chair of the House Government Reform Committee, so a pretty powerful guy when it came to controlling funding toward our public health agencies, including CDC. He has a grandchild with autism. He became allied with anti-vaccine advocacy groups, and he issued a number of, I think, some legitimate criticisms of the Vaccine Safety Data Link project. He said, "You guys have never had an independent evaluation outside the government. You could be covering things up. Maybe when you find associations between vaccines and safety issues, you're not telling the public what's going on. There's no transparency here, and you're not making your data accessible to other researchers." So he actually started threatening a subpoena of our data. And in fact, at that time, Congressman Henry Waxman came to the defense of the VSD project. Waxman actually happened to have this aide named Josh Sharfstein. Josh is a pediatrician. He had just finished residency at Children's Hospital Boston and gone down to be an aide in Waxman's staff. And he convinced Henry Waxman to defend the Vaccine Safety Data Link project. So Waxman started writing these letters to Burton saying, back off and we'll solve this another way. And in parallel, CDC offered to establish a mechanism to let outsiders access de-identified VSD data. So here's one of the letters back from Burton to Waxman saying, I got your letter, and I'll discuss this some more with Gerberding, who was the CDC director at that time. So eventually Burton backed down, but he was replaced in this area by another congressman, Dave Weldon of Florida. Weldon asked Julie Gerberding to move the Vaccine Safety Data Link project to another agency and to change its personnel. And Gerberding instead said, look, I'll commission a review panel because I think the issue here is really autism and the fact that, parents of children with autism are concerned that vaccines may cause autism, and we really need to get to the bottom of the causes of autism. But, focusing on the VSD project is probably not your most effective strategy. So Weldon actually backed off, and that seemed to be an acceptable solution for a while. But then a group of parents brought a case called Sykes versus Glaxo, Wyeth, and all the vaccine manufacturers. And they, in fact, did subpoena all of the HMOs involved in the vaccine safety data link projects for data from a study that we had completed of thimerosal and neurodevelopmental disorders. So any of us who are in pediatrics kind of remember that in the early 2000s, thimerosal was removed from all vaccines in this country because it's a precursor of mercury, or it is a form of mercury. And the concern, a little bit hypothetical, was that we probably just shouldn't be putting this stuff in our babies' bodies unless it's important. So we were defended by our own attorneys. The Department of Justice got involved, and the motion to subpoena was eventually denied. But when you're a researcher, which I was, and this kind of stuff starts landing on the desks of the HMO who is sharing data with you for a project like this, it's pretty scary. And we spent a lot of hours on the phone with Department of Justice attorneys, with our own attorneys, with the attorneys of the other health plans, and with the America's Health Insurance Program attorneys, just trying to figure out how we were going to defend ourselves against these subpoenas. So what happened? There was a lot of pressure here. And I think these threats to the project caused a lot of harms, but they also, through this pressure, resulted in some unanticipated benefits that I think have actually benefited the country nationally. What do I mean? Well, okay, the director of the Immunization Safety Office that houses the VSD project at CDC changed 3 times in 5 years. We lost some very good scientists because they had gone wanting to do science, and they just didn't want to spend 90% of their time defending the work against these internal politics. But in the meantime, the project established new procedures for archiving our analyses, for actually allowing data sharing via the National Center for Health Statistics. So now when you finish a project, you have to archive the data, and someone can reanalyze it. So if you wanted to do it, you actually could, which some people have. But probably most importantly, we stopped pooling data at the CDC. And that led to some really key methodologic advances. So what happened? When we stopped pooling data at the CDC, we started to spawn what I think of this set of modern methods for handling big data. What used to happen was that we'd create all of these data sets at the different HMOs, and these were really big data files, and we would send them on CDs, actually, to CDC, where they would be linked and pooled. But this was not necessarily the safest way of handling our data, right? Because if Dan Burton or Dave Weldon comes along and starts to pressure CDC, the CDC director does not have that much protection against that kind of pressure. And they could make our patients' data available to everybody in the country. And even though we've de-identified the data, it turns out that statistically, if you know a few things about a patient and can link them up, you can pretty rapidly identify who that individual is, even with our modern processes of de-identification. So we changed, and starting in 2000, we said, look, the individual level data are going to just remain at each site and be stored at the sites. And so what we did was to form what I think of as a modern distributed data network. It starts with that common data dictionary that we were just looking at. So everybody uses the same data dictionary. But at all of the different sites, Harvard Pilgrim Healthcare, Kaiser Permanente, Northern California, we have site-based programmers. They select the population and they convert the local data to look like the VSD data dictionary. And then the data actually sit at the sites. And if you're on the research team, and the research team can be at CDC, but it can be in Northern California, it can be at any site, or it could even be at UCSF, right? So if you guys were part of this project, what you would do is you'd have your programmer analysts write analysis programs for the study. They know what the data structure looks like, and they would then send the analysis programs to the site-based programmers. The site-based programmers send back compatible and de-identified data sets from each site. And these data sets are aggregated, so no individual level data actually needs to be shared. This is just another way of depicting it, that the research programmer analysts send the analytic programs, and then what leaves the firewall is actually just counts of the different vaccines and outcomes, the different exposures and outcomes. And actually, it's possible to do a ton of analysis that way. You can do a propensity score matched multivariate regression using these methods. The statistical methods have gotten that advanced. Eventually, you sometimes need to share the individual level data, but the important thing is that you're doing these preliminary analyses with tons of data, but you don't need to share the tons of data wholesale. The other thing that happened was that now that we had these distributed data networks and we didn't have to wait a year and pool the data, which actually often caused 2-year delays in analysis, we started to just update our data weekly. So what'll happen is we create the data set and then we just keep adding to it week by week. And so that was a new system, and people started to say, can we analyze the data weekly so that we don't have to wait 2 years before we know whether influenza vaccine causes Guillain-Barré syndrome? And the problem is actually a statistical problem, that if you take multiple looks at the same data set, even if it's a slightly different data set, you increase the chance of a false positive association. So our statisticians developed a new method for sequential analysis. It's called the Maximized Sequential Probability Ratio Test, and you can read a statistical paper about it. You can read a slightly more accessible description of it, but it's really pretty useful, and we use this these days on every new vaccine that is introduced. And so actually, the public sometimes doesn't realize this, but we actively monitor every new vaccine that comes out. Most of them are fine. Occasionally, we find a problem, and some of our studies, in fact, have changed policy. So we found that measles, mumps, rubella, varicella combination vaccine has an elevated risk of febrile seizures relative to MMR and V given separately if you're a 12-month-old or an 18-month-old. That problem doesn't happen in 4 or 5-year-olds, but this actually led to a change in the national recommendations that people used to say, give MMRV whenever you can, and now the recommendations actually sort of say, weigh the risks and benefits. So I think that was a good outcome. This is another one, which actually it's kind of interesting. A lot of people still don't quite know this, but it turns out that concomitant influenza and pneumococcal conjugate vaccines, if you give them at the same time, they actually lead to a higher risk of febrile seizures than if you give them at different visits. So when you're vaccinating your 12 or 15-month-olds, just so know this. This is now in the vaccine information statement for influenza vaccine, but actually a lot of people don't realize it and don't read it. So anyway, this study's subsequently been confirmed by some more, kind of differently designed studies and more thoughtful follow-up studies. So these kinds of distributed data methods are now used by many different clinical data research networks. And there's the VSD project, but the Cancer Research Network uses this. It's funded by NCI. The Cardiovascular Research Network, supported by NHLBI. There's a Mental Health Research Network, supported by NIMH. Mini-Sentinel has now become the Sentinel Initiative, assembling a 100 million person cohort to monitor drug and vaccine safety. And PCORNet is PCORI's network of networks. Kaiser Permanente is involved in all of these different networks, and we actually share our data with other sites in these networks and with other researchers in this way. So let's switch gears, actually, and I'd like to spend the last few minutes here talking about what parents today are telling us about how to improve the process of vaccinating children. I was chatting with Nancy Adler before coming down here, and Nancy was one of my mentors when I was a Robert Wood Johnson clinical scholar here at UCSF. This is in 1991, 93. And one of the projects I did as a fellow was a survey of parents trying to figure out why sometimes their children missed their vaccines. And I was just joking to her that I've sort of come full circle, or either that or got stuck. But this is a survey of a similar topic. So this is the problem. How many of you here are pediatricians? So we know this. But for those who aren't, this is the CDC and American Academy of Pediatrics approved recommended immunization schedule. All of these yellow bars are different doses of vaccines, and across the top are the different visits that a child who's a toddler will make. there are really a lot of vaccines packed in here. There are 17 different injections at a minimum that will be given between birth and 18 months. And so the immunization schedule is very, very crowded. And this is what parents think is the problem as well. So many parents are expressing concerns that kids are receiving too many vaccines. More than 1 in 10 have now adopted some kind of alternative vaccination schedule where they're saying to their pediatricians, can you please spread out these vaccines because I don't want my child to get 3 shots at the 12-month visit, or I just want 1 shot at a visit. It's a behavior that we call vaccine hesitancy or shot limiting approaches, and it's really hard to know how to deal with this if you're a pediatrician. So we did a study. Actually, we started a project a couple of years ago that got a PCORI pilot project. And, looking back, this is a really simple project. And I think we sold it to PCORI because we said, look, this is a really common problem. It's a problem that every parent, and actually I know there's some grandparents in the room, but, everyone who cares about an infant or a toddler has to worry about. And nobody's solved it yet. So we wanted to understand parents' concerns in a bit more depth. There have been a lot of national surveys of this topic, but we wanted to focus on what causes discomfort in the process and how this can be addressed. And interestingly enough, most of the national surveys have been funded by CDC. And CDC is a little bit reluctant, I think, to have those surveys ask parents the really hard questions about, what's broken in the system here and what do you really worry about? So we wanted to identify, some more in-depth specifics about ways we could improve parents' experience. And we actually just really wanted to give a clear voice to parent perspectives. Because this was a PCORI project, we had a ton of people involved. These are my collaborators at Harvard and Michigan and Kaiser Permanente. But turns out we put together a national stakeholder committee, and this was not so simple. If you guys ever write a PCORI proposal, you will know that one of the requirements is patient engagement. And guess what? It turns out in vaccines and parent preferences, there aren't a ton of logical parents to engage. And the reason is that some of the parents who care the most about this issue are highly polarized. They are, the anti-vaccine advocates. Some of them are very intelligent, and you can work with them. And so actually, Tawny Buck and Vicky DeBold are parents who each have a child who they think was harmed by vaccines. Probably they were, actually, because their kids were affected by an older version of pertussis vaccine, which probably, in fact, did cause encephalopathy or had a much higher risk of that. Jenna Horn was just kind of like a normal parent. She's got 3 toddlers at home right now. And we found her through Kaiser Permanente. But it was actually kind of harder to find the run-of-the-mill parent to participate on this committee. We had some researchers. We had Walt Ornstein, who'd been at CDC, is now at Emory. And so this was our stakeholder committee. They were very helpful to us. We did 3 studies. I'll skip the qualitative study because it actually didn't find anything different from what a lot of studies have. I'll spend a little bit of time on the geographic clustering analysis, and then we'll talk about the national survey. So the geographic clustering study was just something we did because we were trying to find parents for the qualitative study, and then we had these big data sets. And so we wanted to describe whether vaccine refusal and underimmunization, in fact, do cluster. We took children within Kaiser Permanente who were turning 3 years old for about a decade of time, and we wanted to see whether these children received all of the recommended vaccines by that age. We used something called a spatial scan statistic, which basically, if you've ever heard of digital epidemiology, this is kind of an emerging field in informatics, and you see a lot of this kind of work coming out of Harvard and Vanderbilt and the University of Utah, but places that are kind of clever about using clustering and data. But the idea being that you can take existing data and then find where emerging pockets of disease, infections, or social behavior might lie. So we use the spatial scan statistic. And what we did first was to set up a county by county picture of where underimmunizations seem to be. And so the counties or census tracts, actually, these are census tracts, in the red are where we had the most under-immunization, and the ones in the yellow where we had the least, and orange is in the middle. And so this is kind of a nice descriptive map of what's going on within Kaiser Permanente. But then, how do you identify whether there are any statistically significant clusters here? You can use this software. It's actually online, so you go to www.satscan.org, and our biostatistician, Martin Kulldorff, invented this actually a couple of decades ago. It was really meant to be used for infectious disease surveillance, but you can go online and just get this software, and you create SAS data sets, and you send the program data sets with a record for each under-vaccinated child and a record for each fully vaccinated child, and then you have to link it up with their census block group, and then you tell the software where the census block groups are. And it'll send you back something like this. We added, this is actually from SAS, but my program analyst linked SAS up with StatScan. And so it sent us back 5 clusters of under-immunization in the most recent years. It tells us where they are and how many block groups are in them. And then it gives an estimate of the number of expected cases of under-immunization and the number of observed. And you can sort of see that the relative risk in these clusters ranges, but it's about 1.5 to 1.8, and they're all statistically significant. And then it'll circle the clusters for you. So it's kind of cool. This is in Google Earth, and if you open the file in Google Earth, you can kind of scroll around and get down in some more detail. People said, oh, it includes the ocean there, and we said, well, this is statistical, and no, the fish are not under-vaccinated, but
well, they are.
yeah, they probably are. They've got mercury, so they've got similar issues. This what we found was that there are clusters geographically. We don't know why, right? So this paper came out in Pediatrics in January, and I got just this ton of media interest because the measles epidemic was happening in the state, and people kept asking, do you know why this is happening? Anecdotally, I'll tell you that when we look at these clusters, so this one's, like around Marin, and then you have one in the East Bay, and it turns out that, and I didn't know this until we found the cluster, this is east of Sacramento, but when I started asking around, our quality people said, oh yeah, we happen to know that there is this community of Russian immigrants who live in that area, and they're suspicious of vaccines, and they refuse vaccines. And I said, oh man, am I going to tell the reporters that kind of stuff? So I didn't actually, but they found it anyway because they got some California state records, and then they found that there's a lot of vaccine refusal as well as under-immunization there because there's some private Russian schools that I guess, sort of accept vaccine refusers there. So, but interesting enough, there's one in Vallejo, and I talked with the chief pediatrics in Vallejo, and she said, it's not really that these clusters are in highly educated people in Marin. We think that these lower educated groups of parents in Vallejo, they have similar concerns. They just have lower educational status. So, we all have this stereotype that it's the highly educated, highly high income pockets. But I think these pockets actually arise in other kinds of communities as well. So we don't really know. And I think that would be an interesting area if we ever were to link up some social media data with our data. And I actually think that this has some implications for us in quality because, if you're a Kaiser Permanente pediatrician, you really get flogged to do well on quality measures. Kaiser Permanente wants to do well on HEDIS, and immunization coverage rates are the key measure if you're a pediatrician. And I just think that, our poor pediatricians in San Rafael and Vallejo, they would come back to regional meetings saying, look, we just can't do it because we've got so many parents refusing vaccines. And, guess what? They were delighted when we actually found that this is probably true. So let me turn to the national survey, and then I'll quit talking and we can have more of a conversation. The national survey, our questions were, what's underlying the concern that too many vaccines are due at some visits? And how can we improve the vaccination process? And by the way, is it that parents want better information, which is what a lot of us pediatricians are told, just talk to the parents more effectively and you'll convince them to get all the vaccines? Or do they just want more choice? So we asked questions in a slightly different way from the past surveys. We fielded the online survey in fall of 2014. We worked with a survey research group called Knowledge Networks. They have an internet panel that they've recruited. It's representative of the US population. You can pay them tens of thousands of dollars and they'll field a survey for you if you want. And the survey was completed by about 1,200 parents of young children. The response rate was 52%, which is pretty typical of this kind of survey. So how were parents reporting that they had their children immunized? This was not a surprise, actually. About 87% of parents said they're following the doctor's recommendations. About 3% of them had declined all vaccinations. And here's 10% in the middle. And they're doing something different, right? So these are the shot limiters. These are the parents who have hesitancy. But they said, you know, I'm using the Dr. Sears schedule. Dr. Sears is someone who's written a book and said, this, if you want to spread out your kids' vaccines, this is the best way to do it. They have a general approach, but they're not following the Dr. Sears schedule, or they don't really know, and they decide visit by visit. To me, this 3% is actually the hardest set of parents to treat because, you know, they come in and every visit you have to have the same conversation. I almost wish sometimes that these parents would just take the Dr. Sears schedule and then we'd know what we were doing at the different visits. These were the reasons that they gave. So, you know, not surprisingly, most of them said too many vaccines. A lot of them said, I'm uncomfortable with vaccine ingredients. And interestingly enough, we don't have that much research on vaccine ingredients like aluminum in trace amounts and, you know, other stuff that could be in vaccines. Some of these concerns, they were all about the safety of vaccines. It wasn't that we don't think the vaccines are effective. It wasn't that we don't think the diseases aren't common. That comes up sometimes, but the predominant concerns are around safety and too many. And we wanted to probe a little bit farther about what do you mean by too many vaccines? So we asked everyone, not just these, you know, alternative vaccine schedule followers, but everyone. Have you ever had a visit where your kid was due for more than one vaccine? You thought they shouldn't get them all. And 1 in 4 parents actually said yes. And, you know, actually, it wasn't all the parents who were following alternative schedules. 1 in 5 other parents who said they followed all the recommendations said yes. And we said, so what's that about? And these were the reasons they gave us. They sort of said, I wanted to limit their exposure to these unknown ingredients. Oh, that's pretty hard to deal with if you're a pediatrician. I wanted to monitor my child's reaction to each vaccine. That's sort of common sense, right? When we pediatricians say introduce baby foods, we say, oh, introduce them one by one. So if your kid gets an allergy to beets, you know it was the beets. You know, they just thought their child's body couldn't handle multiple vaccines that day, or they had sort of more unspecified concerns. So this paints a portrait of that it's really hard for us. I don't think there are really good answers to these questions. And by the way, more research may or may not help, right? Because, you know, monitoring your child's reaction, well, you know, a lot of more information about vaccine safety isn't necessarily going to do it. So, so we asked everyone, how do you think the process could be improved in any way? Just give us, you know, one most important thing. And about half parents said, it's fine, nothing to worry about. But half of them, more than half of them, said something. And it was usually better vaccine information. But a lot of parents said, just give me more choice. So how would you do that? CDC does not want this. And believe me, I've worked really closely with CDC. I think these are the guys in the white hats trying to protect public health. But they're in a little bit of a bind, right? Because they don't kind of want to admit that it might be okay for not 100% of children to not be vaccinated exactly on time. And so we said to parents, look, you know, we're going to give you some hypothetical alternative schedules. And which of these would you want for your child? So this is one where we said, you know, your kid's going to get the same number of vaccines, but they'll get fewer injections per visit, and you'll have to come back for more visits overall. And 10% said they liked it a lot. Another third said they liked it somewhat. That's almost half of the parents saying, I'd like that option.
Can I ask you a quick question? I'm just thinking about that with the ingredients. So if there's a little bit of preservative in an MMR, for example, and they're concerned about that preservative, that they want to separate it out into an M and M and an R in 3 visits, then aren't you getting 3 kinds of preservative? Because you're giving 3 shots now instead of just one big one.
Right. So in theory, there are definitely some trade-offs here, right? And in reality, they don't actually manufacture measles vaccine solo anymore. So one's choices in terms of alternative schedules are limited, and it probably wouldn't result in a ton more exposure to preservative, just because we have so many combination vaccines. They're hardly making the separate vaccine. This survey was done in the fall before the measles epidemic. But we said, how about your child doesn't ever get certain vaccines at all? And actually, most parents weren't really that interested in that. 5% liked that a lot. Another 1 in 5 said they liked it somewhat. But, by this, my interpretation is that it isn't that parents want to opt their kids out of vaccine, or that's not what most parents want. But a lot of them are saying they want more choice. So what are the implications here for pediatricians and policymakers? Number one, I think current vaccine safety information clearly does not address parents' concerns fully. But even if we were to do a ton more good safety research, parents are probably just seeking more flexibility and control in that process of accepting multiple vaccines or not accepting them. And so the question that this study puts on the table is, should we, in fact, be offering an alternative schedule? We're just finishing writing this paper. I'm a little bit anxious about how to position it. I think it's going to deliver a message that probably CDC does not really want to hear. And I'm struggling a little bit about where to go with this science, because I think that we've gotten as far as we can with surveys. We do a new survey every year, every 2 years, and we probably should be trying more interventions. There are a few intervention studies going on out there, but interestingly enough, most of the intervention studies are about how can we get parents to accept vaccines on time, and they're not about how can we improve the process and make parents feel like they had a better experience. Is that an important goal? Well, I don't know. If you're HEDIS, maybe not. But I think if you're a pediatrician, it probably is. And if you're a parent, it certainly is. So.
Did you do a stratified analysis looking at the vaccine refusers for those last couple of questions? Since it's hard to tell, like there were 87%, right, of people who said we follow doctor's schedule, so 77% say we don't like it at all, but how did it fall out for the other? Yeah, so interestingly, I mean, it sort of fell out the way that you would expect. The parents who were using alternative schedules tended to like the alternative schedules better. But when we removed those guys and just looked at the parents who already followed or who had followed the recommended schedule, a lot of those guys liked the alternative schedules too. So I think this is not just a bunch of crazy parents. I think it's not just the minority of parents. I think a lot of parents feel this way, and they're polite enough not to say it when they're in the clinic visit with us, and they, the default, the easier thing is to accept the vaccines. I think that, there's some evidence from Doug Opel up in Seattle has studied, if you walk in and say, here's the vaccines your kid is due for, it's a little bit of a behavioral approach, and the parent's more likely to say okay than if you walk in and say, what vaccines would you like for your child today? That's not so surprising. Is that okay to do? Probably it's okay to do, but I think there are enough parents who really don't completely feel comfortable with this that we should be thinking about offering alternatives. It's a question of, do you try and find the group and modify behavior in the group only that's refusing, or do you try and modify the whole system to accommodate for people even who are willing to go along with the standard recommendations?
Yeah, well, I'll tell you Kaiser Permanente's answer to this, so that within Northern California Kaiser, there's this program, new educational program for pediatricians called, I hesitate to say it because we're on tape, but it's called the Vaccination Persuasion Program, and it's actually not to persuade all parents that they should receive vaccines. So I think that the title of the program is a misnomer, but it's to educate the pediatrician about how do you quickly separate what parents want. And there's some parents who are just going to refuse vaccines, and we shouldn't be getting into a tug of war with them. We should just be saying, okay, I respect your preference, and here's some information, and how can I assist you? There's a lot of parents who are kind of in the middle, and I think that we all need to learn to be more effective about how to talk with them. And then even within that middle, you could see that people were using a lot of different kinds of strategies. So I think we're really just at the start of understanding how can we quickly stratify the parents that we interact with into these groups. And we should all have these scripts that we use. I mean, most experienced pediatricians do, but yeah.
So I guess I don't know. I think when I think about this from my own clinical practice, I sometimes worry that if we are sort of endorsing or offering an alternative schedule, that we're kind of putting a scientific stamp on something that's not scientific. I don't know. I kind of liken Dr. Sears, I've given the example to parents of, he just kind of came up with this. I could say I'm a pediatrician and I think that the reason that all these kids have autism is because they're, all this exposure to heavy metals in smartphone components, and I could write a book about it and go on a speaking tour, et cetera. And so I guess, that's my concern is that if we offer something as an official alternative schedule, that we're saying that we think that is
okay.
I don't know if it's not that we think it's okay, but that we think that those that spacing out vaccines has some benefit, and I don't think that we at least currently think that, so.
Yeah, I mean, I think that the harm of spacing out vaccines is that maybe the child is a little more exposed to vaccine-preventable disease, but of course we don't really see much hepatitis B or pertussis in those infants. The other harm is that the population might be a little bit more exposed. So I think we really do not know whether alternative schedules are equally effective. On the other hand, it might be hard to argue that they're less safe, and that's what I think parents are after, that intuitively it just sort of seems like, why would you do 3 shots at a time if you had the option of doing 2 today and 1 later? I don't know.
Why for the child?
True. Actually, there's a fair number of parents who are following recommendations who say, yeah, let's just get it done. And, that would be me, actually.
No, but I mean, I think that's part of the scientific is using your database or others, can some science be brought to bear to walk parents through this trade-off between a longer duration of exposure relative to any harms they perceive to be associated with following the schedule, so that it's, it's a reduction that's not just somebody made it up, but okay, here's a plausible alternative with some, yes, there are risks, but how big, I'm saying, is there a scientifically defensible alternative schedule?
Yeah, actually, one of my collaborators, Jen Salmon at Hopkins, has for years been proposing this type of study. And actually, there's an Institute of Medicine white paper out on, how would you study the safety of these alternative schedules? And it turns out to be complex and difficult to do methodologically, but probably feasible if you were clever about it. And so Dan has been proposing this, and he can't get anyone to fund it. Mm-hmm. It's really, it's not simple, but there's a lot of politics involved, as you might imagine. Let me just take a step back and wrap up, because I think that what I want to leave you with is this big picture of, the idea that science and policy evolve, and that when we have these policy and political and privacy pressures, they actually force us to be more creative. And so I think that when you look at vaccine safety research, these policy and privacy challenges really force the researchers to find some creative solutions, and now we know how to better handle big data. I think that we as pediatricians have parental vaccine hesitancy, and it's a huge challenge for us. And I don't know how we're going to solve it. But my hope is that if we're persistent enough about it, and if we're creative and we try a whole lot of different things, that eventually we'll come to a common understanding of how to better personalize healthcare. And if we can figure out better ways of personalizing in this area of healthcare and figure out some generalizable approaches, that will be useful in cancer and decision-making around surgery and many other areas that don't just have to do with child health, kind of in the same way that some of these methods for big data have now generalized beyond vaccine safety. So, the idea that trying to do something a little impossible will inspire us to do things that are a bit more creative. Yeah. Charlie.
So I was going to just kind of raise the issue that we're one of the few countries in the world that delivers vaccines in clinical delivery systems. And the real issue is whether this is the right model, and other countries in some vaccines have much better uptake rates because they're not delivered in clinical delivery systems. So I just was raising this as an issue. From my perspective, vaccines consume a lot of time in clinical practice, which I think is personally wasted time when physicians maybe should be doing something else at that time. So I just wanted to get your insight into this.
Yeah. It's sort of interesting. Actually, one of my daughter's teachers once said to me, I need an influenza vaccine. Should I go to my doctor or should I go to CVS? I said, go to CVS, right? And I think what you touch on is the perverse incentives we have in a lot of healthcare. A general pediatrician earns, in fee-for-service practice, earns a lot of their money by doing well child visits. And, did you really need the pediatrician to have a 10-minute interaction when you have a basically healthy child? There's this kind of interesting institute in Cambridge called the Institute for Complex Systems Studies. And the guy who runs that institute has a hypothesis that in healthcare, what we really ought to be doing is partitioning the services that are routine and simple to get and sending them to the CVS or other simple places like the Minute Clinic, and then reserving doctors for the really complex interactions that we need to have with our sick and patients who have multiple comorbidities. And Steve Schroeder probably has something to say about this, but I think that that's a really intriguing idea. It's probably elegant and efficient, and I don't know if we're ever going to get there in American healthcare.
But you guys are, as a Kaiser member, you are already on the adult side. Do that a fair amount, especially,
even on the pediatric side. Yeah.
So my doctor's not wasting her time giving me injection. We have the conversation about, okay, what should you get, for travel or other, and then I've got it in the electronic record. Go down to immunization clinic, the nurses will take care of you. So I think it's the trial. To Charlie's point, I think it's already there, but the incentives to do it in Kaiser are much different than in fee-for-service.
Well, some of the cost analysis have shown that it's not a money-making proposition. It just depends where you practice and how you do it. So it's not
True.
Necessarily you have to employ people to do this. The cost of doing it, you eliminate. With HPV vaccines, we had to hire an additional person in our clinic to deliver that vaccine. So are we covering? There's kinds
so you're saying
of
even on the
things. So
fee-for-service side,
I'm not totally convinced it's driven by.
Is there pushback in other educated countries comparable to the U.S., or do we stand out?
I feel like we stand out, Steve. You look at England, for example, and they don't really use pediatricians for child health care, child care.
GP.
Yeah, pediatricians are specialists. And I think that this actually is going to pose a problem.
No, I mean, is there pushback from the parents to the extent that there is in the United States?
No. About vaccines.
Yeah, about vaccines.
Yeah, there is.
Is it comparable?
I think it is, actually.
That surprises me.
Yeah, the little bit that I know about other countries.
I was actually happened to be in the UK in 1980, for example, which was the height of the anti-pertussis
Yeah, that Lancet
episode, and
article.
I was there, I actually had a child that year, and so, and I actually was in a family where no one got it, and then everybody got whooping cough. So yes, so it was a real problem, and this was in London.
Yeah.
I
Yeah.
wonder if there's been any collaboration with OBGYN or like thinking about how different disciplines can collaborate more to provide the education earlier on, for when like
Yeah.
the parent is like overwhelmed with all this new information and kind of having to decide about vaccines and kind of how can it get introduced earlier on in the process.
Yeah, for sure. There's actually this interesting study going on at Kaiser Permanente, Colorado. So researcher Jason Glantz is randomizing pregnant moms to usual care, social network, or internet based information. But he had done some focus groups and found that a lot of moms were saying, look, I really wish someone had presented me with the option of discussing this earlier before I arrived at that 2-month visit. And for us as pediatricians, it's kind of miserable if the parent arrives at the 2-month visit and they don't know anything, and that's what often happens. So yeah, I think the world is moving toward let's do it in pregnancy, and then the question is, do we need the OBGYN support, or if we have a population-based system, maybe we just find the moms who are making prenatal visits and offer them some other approach. Last question.
I'm distressed that you can't get funding for doing some studies that would actually address these questions. What better policy could there be in this area than to get more information about it?
Yeah. Well, the CDC, interestingly enough, is not really a powerful sponsor of research. So they will do collaborative research, they will fund some projects, but the NIH has multiple millions of dollars more every year to fund research. And for some reason, Dan tells me that NIAID is just not interested in vaccine safety research. They probably think it's being done by CDC or FDA. And CDC and FDA fund epidemiologic studies, but they don't tend to fund some of the immunologic studies that would address the question Janet put on the table. So it's complicated. It falls through the cracks. And yeah, I think part of it is we don't have a patient advocacy group, kind of like HIV or breast cancer. The advocates tend to be seen as very polarized, and then they don't gain the endorsement of the funding sponsors. So it's an interesting problem. Anyway.
Thank you so much.
Thank you.